I graduated residency in 2007, which is roughly the peak of the opiate crisis, maybe a little bit before the peak. But I was very much taught in residency, and I remember several lectures hearing that, okay, pain is what the patient says it is. There's no ceiling dose on opiates. If the person is not getting good pain relief, you gotta not be afraid to just push the dose higher and higher and higher. And I believe my teachers, they were good, well-intentioned people who didn't want their patients to suffer or be in pain. So I would happily push doses higher and higher and higher. One particular case that comes to mind, I saw a lady who, she did have a few health problems, a few back issues. In hindsight, nothing that really merited the kind of treatment that she got, but she was getting about 180 milligrams of morphine per day. And when she became my patient, she transferred care to me. I didn't have a whole lot of second thoughts about that. That seemed reasonable and okay at the time, even though now looking back, I realize it's kind of terrible. And her pain was never relieved. Never in a trillion years did she get pain relief. She was miserable, she was hurting all the time in spite of being on 180 milligrams of morphine a day. Why was she miserable? Because she probably had something called opiate-induced hyperalgesia. If you take too much pain medication for too long, it actually makes your pain worse instead of better. I had no clue what that was at the time. I thought maybe she wasn't on enough, or needed a higher dose, or needed a specialist, or was missing a diagnosis or something. Before I could really come to any of those answers, she wound up moving out of the area, so transferred care to somewhere else, and I don't know what her subsequent doctor did, but she's kind of an illustrative case, I think, of how little I knew when I first got out. And to be fair to myself, I think I was a pretty bright guy who believed my teachers. I tried to do what was best for my patients. I just, honest to God, didn't know any better. My prescribing habits for opiates, which I do still prescribe because they are effective painkillers and they work, but one, I'm a lot stricter in a whole lot of ways. I make patients follow up. I make sure they're doing other things for their pain. If somebody is smoking, I won't prescribe them pain medication because it's been shown cigarettes increase pain and that increases the risk that they're going to abuse other substances. If somebody refuses to go to physical therapy to lose weight, if they need to lose weight, to see a specialist, I won't prescribe them opiates. They say, this is, if you want your pain to be better, it's not just take pills, it's take pills and do these other things. And I have very strict limits on how many pills I'll give somebody a month. I don't care what the source of the pain is at all. Most of the research that is out there right now says that giving any more than 40 milligrams of morphine equivalency per day doesn't help any extra. So I follow that limit pretty strictly, where I say, if you're at the maximum dose, even if your pain is not relieved, I say, I'm sorry, this is really as good as we can do for you. It's not that we can't try some other things, but increasing the medication is not one of those things. And one of the issues that we physicians run into is a lot of people want a pill and don't necessarily think that they can do anything else to make their pain better. Quitting smoking helps, exercise helps, meditation helps, just having a pet helps, getting married helps. There's all sorts of things people can do. It's just a little more time consuming. Taking a pill takes no time at all. Exercising takes a half an hour out of your day. And especially if it's something a person's not used to doing, they don't necessarily see that as an effective way to go fix something.